Up next, we have a panel discussion. We've got about 45 minutes. I'm really looking forward to this. Tammy's going to join us on stage to facilitate this session, along with Dean Fina and Sally Hughes, who I think is joining us online. Hope she is. It'd be great to see her. Is she joining us?
Yes. All right.
Okay.
Thank you. So I think we're going to be bouncing between mics here, Dean.
Okay.
All right. Well, good morning, everyone, and thank you for joining us on this panel this morning on multidisciplinary care and organizational approach. I'm going to first introduce our speakers, and then they're going to have some presentations to help present different ways that they're considering approaching multidisciplinary care. And then we can have a bit of a panel discussion following that. So first, I'd like to introduce Dean Fraser. He has a career spanning 30 years in the nonprofit and technology sectors. Dean brings a broad perspective in making data a significant part of the value of an organization. He focuses on new approaches to problems and enjoys the opportunity to blend solutions from different perspectives. In his position of Chief Information and Marketing Officer at the ALS Association, he leads both the data and technology team as well as the marketing and communications team. Dean?
Thank you so much. Hi, everybody. So I'm Dean. You may hear me sound periodically like Tammy. I was born in Canada, although I currently live in Atlanta, Georgia. I'm going to be super quick with this because it's just mostly stuff that you've seen, right? So first of all, if you were here on opening day, you saw Maury and Lori up here, and they talked a little bit about data and overlays and geographic analysis, geospatial analysis. This is just a look back at that, and it's, this happens to be a heat map, if you remember, and we were talking about, where the density is for people and where there's space and all that kind of stuff. So there is a lot of information we have, and so what I just want to take a moment and talk about, just with a little bit of depth, is the answers to getting more people into multidisciplinary care. You may be wondering, why is the Chief Information and Marketing Officer talking about multidisciplinary care? I am not on the mission team. But data is really important, and communication is really important. We just heard the previous speaker say they want to translate something into Spanish. We know this, about 60% of people who live, jeepers creepers, sorry. Can you all hear me if I stand back here? Good, and it won't bang on my thing. Thank you, thank you. We know about 60% of people who live within a drive time radius standard actually still only attend clinics. So there's still 40% of people that don't. So there are other barriers, right? And so maybe we want to think about some of what those barriers are. The other thing is, as an organization, we're really interested in the expansion, diversity, equity, and inclusion, and that just doesn't mean in our hiring practice. It has to mean in our service, and how do we look at communities that are underserved? So just another couple of examples, right? Medically underserved, social vulnerability. Maury talked to you about what those data sources are. And as we begin to make decisions about care, and as we begin to make decisions about service, we can include other levers that help us make decisions that maybe advance goals that we want to have. So it's not just about necessarily putting a clinic in an area where there isn't one today. There are multiple problems, and the problems that affect people who live within the standard of a drive time, which is a really kind of normalized standard we all use, the problems that exist in there are different, and they need to be solved differently than the problems that exist. You heard, I don't know, someone else, I'm terrible remembering who it was, talk about the white space when we look at where our clinics are, and there are vast swatches, undoubtedly around the world, by the way, where there are spaces where there is not service. So the solutions there are different. So that's just another thing. We talked about just then about doing meetings by Zoom when David was talking this morning about Cali. And they're doing things by Zoom. Canada is a vast country. The United States is a vast country. But that doesn't mean that other, maybe more localized places don't need to use technologies. But undoubtedly, everywhere we deal with this. Where do we have places that don't have easily available internet connectivity? And how do we manage that? We can't just say, well, Zoom is the answer to everything, because here in America, and again, I assume all over the world, I know when I go to visit Newfoundland, there are places where there's just no connection for anything. Zoom is not the answer for everything. And then while some of this may be kind of specific, even around health insurance coverage and how do we manage that? So how do we look to increase how we are expanding access to multidisciplinary care, which we all know is advantageous and leads to better outcomes for people, which is really, oh, look at this. You can even, by the way, because it's all just public information, right? When Maury presented, she talked about Pat. You saw Pat in the video with Amanda. Pat does all this stuff and builds a lot of it. And this is, again, just congressional districts. If you want to know how many people in a congressional district are living with ALS, this is our data. Pat works for us, NDA, so it's all good. But we can even drill down into that. You can also, by the way, find voting records. I assume that that's normal everywhere. We actually have another map on Pat's Mappers thing where you can go and see who is the person in that particular district and how did they vote on legislation that's important to us. So in the United States, Act for ALS, that sort of stuff. But here's what's really important for me is this sense of transitioning care and the way that we talk about care from recording actions. They came, I gave them a chair, they took a course, we gave them a certificate, to measuring outcomes. We do this in other aspects of the things that we do. If you think about research and clinical trials, that's all about outcomes. We gave somebody a drug, somebody's on a drug, someone's on a placebo, they had these outcomes, they had those outcomes. The outcomes is actually how we measure efficacy. We do the same thing in development. I spend money on wealth overlays, so I know that Dean is going to get an ask ladder that says, give me $10, $25, or $50, and Tammy is going to get one that says, give me $100, $250, or $500. We know that when we use that information, we have an outcome we can measure. We have an elevation in standard average gift. So we see those things. I would love for us to figure out and to start a process of using care as another place that we can move away from measuring. I gave a chair, I gave a piece of DME, I made a visit, they came to a clinic, they graduated, to what those things are in the outcomes. I really want to see our data as an association. I want to see our data become part of the stratosphere that's useful information for measuring those outcomes and helping us as organizations fighting against this disease do better things for our community to actually make measurable difference. There.
Thanks, Dean. I already am scribbling down a ton of questions. So next we're going to have Sally Hughes, who is the Assistant Director of Care at the MND Association. And I love what their promise is. We won't rest until everyone gets the care they need when they need it. And so Sally also leads the association in the regional care teams, as well as working cross-organizationally across England, Wales, and Northern Ireland. Sally has a long history in healthcare and health foundations, and she's absolutely passionate about the long-term conditions agenda and improving person-centered care with her career to date, including a focus on improving lived experience. And so now we're going to hear from Sally.
Hello there, my name's Sally and I'm the Assistant Director of Care at the MND Association. I was delighted to be invited to join this panel and I'd like to share with you over the next few minutes our experience of what we think are the building blocks that we've established to put us in the best place possible for delivering in the future excellent multidisciplinary care for all people living with motor neuron disease. So our journey today, I want to share with you some of our learning from the work that we've been doing and hope that from this you get some really actionable insights to support your own plans to improve multidisciplinary care. I want to take you through the foundations that we already had in place at the association, some of the thinking around our blueprint for the future really that aims to embed multidisciplinary care into all of our work, the essential elements that we've designed as part of this programme that we think are crucial for delivering a sustainable model of multidisciplinary care in the future. What we've put in place so far, so what our first builds look like, where we've got to, and some of the crucial next steps that we're looking to embed to make sure that we can deliver on our vision. And finally, I'd like to share with you some reflections really about where we are in relation to our work in this area and how far we are away from achieving our vision. So just to put this in context initially, I'd like to just remind everyone that isn't aware that in February this year we launched our new strategic framework in the form of promises we've made to people with and affected by MND who live across England, Wales and Northern Ireland. We've promised that everyone gets the care they need when they need it. But we know, unfortunately, that the quality of your MND care and even the speed of your diagnosis still depend far too much on where you live and who you see as part of that. The MND Association has a proud history of supporting and delivering, through our network, improvements in access to multidisciplinary care to improve quality of life outcomes for people affected by MND. And I'm sure the experience of not having equal access is something that resonates with you all on this call today. Access to specialist multidisciplinary care, we know, is associated with improved survival. But as I've highlighted, access is not universal. For the last 30 years, the MND Association has facilitated the establishment and growth of MND care centres and networks. We have 22 centres working across England, Wales and Northern Ireland that really focus on improving our ambition to achieve our vision that everyone has access to the care they need. However, we know there are parts that those care centres and networks aren't able to reach, and so to address this we included our ambition as part of our new promises to look at a dedicated focus on improving that issue. The work that we do will only be able to be possible to achieve our aim, listed here, if we work in partnership with our ongoing partnership with MND care centres and networks. That is a crucial foundation for the work that we've been doing over the last 18 months. So to help with our vision, we wanted to set some design principles or a blueprint to help guide our plans. Hopefully these are self-explanatory and I'll let you review those as I talk, but I just want to highlight a few key things we did that resonate with the points made by Dean. Firstly, the point around inequity. It was really important that we were able to identify, based on solid data, intelligence and principles around co-designing with staff, volunteers and healthcare professionals, the areas of greatest need. We know that this is going to be a long journey in terms of improving and achieving our vision of everyone getting access to multidisciplinary care, but it was really important to have a targeted, laser-eyed focus on the areas that we did want to improve as a first priority. Data really helped us to achieve that. We wanted, secondly, to make sure the importance of innovation was built into the work we were going to be doing. It was important that we were willing to test, learn and iterate as we went along, remaining focused on the outcome that we wanted to achieve, rather than deciding that there was a solution that followed a prescriptive formula. That allowed us to be much more responsive to local needs and ensuring that what we were doing fitted with the existing services and infrastructure that already existed around meeting the needs of people with motor neuron disease. Finally, I'd just like to highlight the importance of building evidence on what works. We've learned along the way that it's really important to build a strong case for change that identifies both improvements in the quality of care, but also the evidence around the financial, economic benefits for putting in place these changes. As we develop and grow more services with a view to changing national policy as well as what happens on the ground in terms of local practice, we're really keen to make sure that the work that we do is built into evidence and that we're able to share that evidence with others and embed what works. Hopefully, part of what we're doing today will support that. So what we set out to do in terms of those essential elements, I've already talked about the importance of the evidence base around targeted plans to create community specialist posts in defined priority areas to make sure that we're expanding both capacity but also the areas that those posts were covering so that we're reaching parts that current services weren't able to reach. Secondly, we wanted to develop a network for accelerating change to make sure that we were bringing people together to put pathways in place that would enable good multidisciplinary care to be put in place. And finally, we know that we need to create tools and resources to support the ongoing work and building the case for change And we wanted to make sure there was a toolkit available to make sure that we were following that principle of sharing the learning that we have through this work. So just to dig into those a little bit more in a bit more detail, when we looked at the work around community specialists, I've highlighted that it was really important that we had a really clear gap analysis about the areas that we wanted to focus on and prioritise. To support that, we actually also secured investment to put in a partnership funding model that would look to leverage investment from both the MND Association to recognise that we felt these was a priority, but also that would be a partnership model that would be supported by the NHS, so by health communities, to make sure that they were putting their investment in alongside ours. That was a new investment on top of the existing MND Care programme that I've mentioned earlier. I've highlighted the importance of evidence in the principles, but one of the things that we also wanted to put in place was to make sure that we got an evaluation partner that could work with us to gather the evidence and to be able to put that into information that could influence in the future national guidance, such as the National Institute for Clinical Excellence standards around motor neurone disease care. And crucially, we want to make sure that we've got a really powerful collective voice to demand change. It's a very noisy environment at the minute, post-COVID, to try and get cut through around what the priorities are. And there are many people banging at the door of decision makers to say that their case is the most important one to be heard. It's been really important to be able to talk with one voice and a collective voice with our volunteers, with people with MND, with our stakeholders in healthcare professionals, to say this is important and to make sure that we were speaking with one voice. In terms of some of the activities that supported our commitment to develop a network, we wanted to have a new approach that would build on the work that we were already doing in terms of bringing together healthcare professionals through our new national community of practice that brings together over 800 healthcare professionals. But we know there needed to be an engine room that really embedded some of the work around multidisciplinary care to be conversations that were supported at a regional level, some of those more local community discussions that understood what the local need was about. So we are developing local forums coordinated by MND Association staff to support those discussions to be really built together. And we'll look to learn and collaborate and share that information and evidence that we gather through that work through our national community of practice so that we can continue to keep a focus on this work as we move forward. And our toolkit really will make sure that, again, we use the information we have already at our disposal, such as the Transforming MND Care Audit. We've launched a new modular tool that is meant to be supportive and enables community services to identify gaps in their services. So we're more responsive to be able to identify and use that information to identify gaps in care. We also want to make sure toolkits and evidence are available to support business cases. We know, as I've said already, we need to evidence quality improvements, but also the financial case around why this is important and why this makes sense. So we're pulling together data to prove why this will benefit both the financial case, but also the quality case, and templates and negotiating guidance to support that. And finally, we'll make sure that that best practice evidence gets shared and learning will be spread about what good practice looks like through a variety of channels, including the ones I've mentioned already. So what have we done so far? So we deliberately set a fairly modest target to recruit to 2 community specialist posts by the end of December 2022. As of today, I can tell you that we've achieved our target to recruit to 2 community specialist posts, and we've secured that commitment. We are already making good progress, and out of the 14 remaining posts that we've identified as a target area, we have priority cases being put forward and partial commitments to 10 of those. So we expect those all to go live by July next year. We've also commissioned an independent evaluation to help inform our blueprint for change and to influence future care standards. That all important evidence base. We are actually coming to the end of the dedicated programme work that we've established at the end of this year, but that means that we'll be looking to mainstream the programme into our existing work. That doesn't mean that we'll lessen our focus on this, and we'll be looking to embed this within our performance framework to make sure that we keep a sustained focus on that. So we need to make sure that we continue to recruit and deliver on those plans that we've got in place in terms of delivering on our 14 community specialist posts being in place. We want to make sure that we embed the toolkits that I've mentioned and also the regional forums. And we'll do that primarily through our existing regional care teams that we have in place across England, Wales and Northern Ireland. Again, recognising the importance that context is really king in terms of being able to create the case for change around many of these priorities. And crucially, we'll continue to test, learn and iterate around the work that we're doing. Being seen to be responsive to the environment and external environment in which we're working is really important. So have we achieved our aim? Well, what we can't say is that access to quality assured multidisciplinary care is available for everyone. But what we can say is that through this work, we know it is available to more people, and that the benefit of multidisciplinary care is more widely known about through the range of activities that we've been undertaking. We can also be confident in that we've been innovative in our approach and making sure that we embed that learning really about what is new and useful into the work that we do. Some additional benefits that we've also delivered is that we've actually been able to, by being on the front foot with this programme of work, been able to be at the first to the door really of the new decision-making structures that have been set up in England. So there are new integrated care systems now in place that make decisions around priorities for health systems, and we've been able to be at the front of that queue really in terms of being able to put forward the business cases, which has been really positive. And as part of that, we've tested negotiation skills of our staff teams to make sure that we're working in partnership on the recruitment of community specialist roles. We've also managed to include the benefits of multidisciplinary care and the progress we've made as part of fundraising campaigns, and they've been really successfully and well received. And as I've said, we'll continue to test, learn and iterate. So we may not be at the finish line, but we're confident that the start that we've made will put us in a really strong position for delivering on our outcomes. I hope that's been a useful learning and reflection for you. I've included my details in the slide here. If anyone would like to reach out to get further details about some of the work that we've been doing, we'd be very happy to share. And I look forward to discussing with you in the panel that follows about some of your questions and feedback around your own learning, but also things that you think we can help support. Thank you very much.
Thank you very much, Sally. I wonder if there's ever a finish line, and that's something I think about from our community's perspective, that there's always more to do, for sure. And so have we been able to get Sally to join us online as well? All right. Good morning, Sally, or I guess good afternoon for you. Thank you for joining us today. All right. And Dean, maybe we can get you at the podium as well, and then we've got dueling mics that we can play with. So as we were looking at this, I was actually struck in thinking about the graphic that Lauren had showed that we're so famous for at ALS Canada, the information, the knowledge, the wisdom. And I was thinking about how data is actually at the start of that, and then how we get to those outcomes that you were mentioning, Dean. Maybe you could talk a little bit more about how that translation moves from data into outcomes, actions, and then outcomes.
Sure. It's an interesting marriage we have because, as I said off the top, I am not, I'm not in the care space. I'm not in the mission space. So I rely really heavily on the team we have over there with, starting with Neil Thacker, Dr. Thacker, our mission officer, and down through experts. You heard, Tracy made a comment earlier in a session for people to help us determine what are the pieces. And then we really see our job as figuring out the right way to capture and hold information and make our systems useful for people, because that's another really important thing. Perhaps all of us, we put a lot of investment into the systems we have. But if they're difficult to use or we are unable to tailor them to capture the information pieces we have, we'll never make the transition. We'll have data that we won't be able to move to knowledge and move to wisdom, right? Because data is really just raw material in that process. So we really do look for great partnerships with cross-functional teamwork in our organization to do that.
Great, thank you. And well, you talked about the types of data. Maybe Sally, you just mentioned data. Where are you sourcing data from for your organization?
I think primarily many of the things that Dean's just identified are going to be our experience. I suppose particularly with the work that we've been doing, what we were really keen to do was just make sure that we got the measures of success, not just about the organisational learning, if you like, so what the benefits were to being able to offer good multidisciplinary care. We were able to make sure that we could demonstrate ultimately the outcomes for people living with motor neuron disease and their family caregivers as well, but also to be able to apply that beyond just the local area really, and making sure that we were able to lift that up a level really, to be able to make sure not just understanding what works in a local community, but to be able to put that alongside all the different areas where we're testing rollout of multidisciplinary care, to be able to say, what is it about a local area that's making this idea being implemented really well? And what are the features of that local system that make that and support that? And what are the things that actually are different in different areas? So what are the components that make something implemented well or not? So we want to lift it up to more of a programme level. So rather than just gather the information by each area, we want to be able to look at that across all of the programme to understand what makes the difference really. So to see that right across England, Wales and Northern Ireland from our point of view, we'll actually be able to say, okay, how can we translate that to national change, as well as actually making sure that we can take that learning and say, okay, this is how we've done it in one area, we want to be able to share and spread that in other areas as well. So making sure that we're able to lift up and kind of learn really beyond the initial sites really that we're working with.
Okay, thank you. Dean, did you have anything you wanted to add to that?
I think it also was going to require us to do some things new as well. When we think about building this sense of our data leading us to outcomes, there are many ways that the transition is required for that. If you think about, for instance, there's a doctor in Atlanta who, when we were at the NEALS conference a little while ago, presented a paper or presentation about a way to do ALS FRSR scores over Zoom. And they use a statistical model so that you can run through a bunch of things with somebody. You don't have to be present. So we need to begin to think of how we integrate those pieces of data, to the point of being able to build not only just this sense of value from multidisciplinary care for community and having people part of that, because it is important. But again, as we're looking to expand and move those things beyond, ways to capture information that lets us know as we're providing programs that this program is successful, not just because people like it or not just because we're proud of it, but because it impacts the lives of people. Those are the things I think we really want to get to.
Thank you. And I'm curious, as you've got two of the larger organizations with more resources and people that have these skill sets, what would you suggest for smaller organizations that may not have those resources embedded within our organization? How could we approach it? Often organizations kind of look to consultants when we don't have the internal. Do you have any recommendations for how we might gather data and consider it and start off?
Yeah, I think one of the things I wanted to hopefully showcase when I did my really kind of brief slide intro that I did there is that a lot of the data that becomes useful for us is not necessarily data that we have created or curated. We use a lot of data that comes to us from government sources in the deck and in Maury and Laurie's presentation. There's things from the CDC, there's things from the National Institutes of Health. There's, the information on Wi-Fi and wireless internet connectivity. We didn't create that. So I think the first part is really trying to inventory what data sources do you have, where can you then identify gaps that help, because there are a lot of gaps, undoubtedly. So if you have an idea of the endpoint you want to get to, the available sources of data that you can get just without having to curate it yourself, maybe one of the keys in smaller areas is to have a focus point and then just fill the one gap that you need to do that. And I think that's the sort of success that can help us become more efficient as organizations, large or small, and provide impetus for partners to want to be part of that journey with us and help us to grow kind of the overall volume. So that's what I would say. But
Thank you. Sally?
Yeah, I think many of the points that Dean's made are really true and valid. I think the other point that I would make is the importance of looking outside of motor neuron disease or ALS in terms of the experience from other organisations. This is a shared challenge about access and barriers to multidisciplinary care, and there are lots of resources available to talk about how we can build the evidence-based measures of success in different disease areas, particularly in progressive neurological conditions. So in a similar vein, really, to the point that Dean's made already, that actually there is already quite a lot of information out there. And certainly, we're very happy to share the learnings we've got in terms of the toolkits we're developing, because I think it's important. That's the ethos, really, of why we're here, isn't it? About sharing and learning together. But I think there is also the potential to learn from other similar conditions and other organisations that are doing a lot of work in this space, really.
Excellent. Thank you very much. Maybe we can take a few questions before we come back to mine. I feel like I'm hogging the mic here and the opportunity. We have a question at the back of the room.
Dean and Sally, I wonder if at some point you will have something that you would be able to template, I guess is the best word, where you know what inputs you've used that have led to the best outcomes, so that other people can take that. And you've just mentioned that there's lots of different data sets available, and other countries might have those data sets available too. But if you know the ones that are most meaningful to achieve the best outcomes, when do you think you might know something like that, and would you be able to create something universal from that?
so, yeah, solve the world's problems. Thank you, Kathy. I appreciate that. No pressure. There are certainly lots of data sources. They're different everywhere, of course. I would anticipate, Tammy, I'm going to look to you side-eyed. You'll do this if I'm completely wrong. So I mentioned, as an example, for advocacy, I showed you a map of a list of our congressional districts in the states of Minnesota, North Wisconsin, and whatever it was. It was someplace over there. Canadian, give me a break. And the people who are registered with us in those areas. And I told you that we can find the voting records for our members of Congress and members of Senate. And so we can look at, again, this is one small example, as advocacy, and say, can we look at data from Canada to find out if there's legislation that's important to us, and figure out who I need to connect to, who is the member of parliament, provincial parliament, who is the member of the national parliament there, what is their voting record on the things that I'm interested in, and how can I connect to them? So I think, Kathy, those sorts of things become a little easier to make universal. There's a lot of really interesting data geographically that perhaps is a little more difficult to make universal, but certainly we've got a great team. We are fortunate at the ALS Association. I have fantastic people. You met Maury, you met Lori, who's on Neil's team. We have people who know how to build things. So I think we could build templates for how data gets used. And I think it's not difficult to begin to understand how you would insert or interact that data into some of those templates. So I think we could get to a point of building maybe not a template or something that is easy, but I think it's depending on the area. I think it would be possible to show people how we use data, and perhaps more importantly, how we not just integrate the data, but how we're working cross-functionally in our organization to make the decisions we want to make about those things.
I hear secondment in Maury's future. So Sally, next.
I mentioned in my talk about the fact that we've commissioned an independent evaluation partner to learn really about the work that we've been setting up over the last period of time. And so we've set up that partnership, and that that piece of work is deliberately designed to be action research, so to learn as we go, and as we set up and initiate those posts that are coming into place and those areas of work that we're putting and implementing over the next period of time. So there will be interim stages, basically, as we go through that action research to share learning, share feedback, and to come to Kathy's point about what are the key kind of inputs that are working and the things that aren't. So we'll be able to share as we go. The ultimate kind of final evaluation will be at the end of the 12-month period with that evaluation partner. So that will be the final product, if you like. But there will be things to share as we go, and we're very happy to do that. And I think that's, again, the kind of key crux of why I wanted to make sure that we'd got an independent evaluation, was so that we actually had something at the end of it to be able to say to people, this is what worked, this is what didn't work, and these are the things that we're now going to make sure are embedded in future practice and future things that we do. Again, very similar to what Dean was just saying. We need to make sure that this is instructive for the things that we do in the future.
Great, thank you. Other questions? At the back. Lauren?
Sally, I'm just dancing with joy. We always look to you for mapping out strategically what logically are the next steps, and following that path and that plan. And I think we have a lot to learn from our colleagues in the cystic fibrosis community. 10 years ago, they published about their learning and leadership collaborations in the British Medical Journal, and it really was all about activating people living with CF, parents, as well as multidisciplinary providers. And they really created and cultivated a sense of community and building and trust, where there was vulnerability in addition to data, and then they used that to improve the quality of the care. And I'm so inspired by this work that you're doing, and I can't wait for us to, down the road, do what CF does around quality improvements, and where we're honest and we share our data. So thank you.
Thank you.
It's always interesting the number of times that you hear certain other diseases that we look to, and the organizations that we look to see their thought leadership or their experiences. And cystic fibrosis, MS, tends to be two of those that come up over and over again. Any other questions? Yes, here.
I was just going to go back to the template that Kathy mentioned. Thank you. Simple, just get started type of searches for those that may have smaller organizations. Type in GIS, see what comes up, because in order to create a map, you have to have the data to support it. And so doing that kind of search on GIS, you'll, one, see if that occurs in your country, at your organization, but it also is usually attached with some sort of data set in which then you can pull information. We also pull from the census, our national census. So yeah, just get started on what you're looking for, but for a mapping perspective, definitely type in GIS, because that's going to be the beginning of the mapping world. So, and you'll probably see Esri. Esri was what Pat and Amanda worked on, and they have a boatload of sources. So, and they are a global company, so you might
Familiarize yourself with Alice in Wonderland before you type in GIS, because you will go down the rabbit hole.
Yeah.
There's a
yeah.
lot of information in there.
But it's really cool.
It is.
Excellent, thank you. Any questions on, at the back?
So one thing that Sally said got me thinking that, when we talk about outcomes and measures, so not only are we thinking about better measures for the care we deliver that are related to impacts on people, so things like services people receive, but also the complications that people may get as a result of their ALS. If we had better data on those things, we could start to iterate on ways to reduce falls and hospitalizations related to infections. But the other thing about systematic assessment is that research programs also have outcomes, and I think that's an important part of what we do, to think about the time we expect the outcome to come out of a research investment, and then also to start to think about the productivity of those different research investments. Thank you.
Thank you, Neil. Other questions?
You've got Kathy at the back again.
Okay, thank you. Kathy?
Sorry, I forgot to say who I was when I asked the first question. So for the online folks, Kathy Cummings, Executive Director of the International Alliance. Just bringing it back to multidisciplinary care and data and access to that, have you already found through your work that you've both done already something to do with distance that, that can be a takeaway for people here today in terms of how far away from multidisciplinary care makes a difference?
So I'll go first, Sally, if that's okay. Okay, I'm looking at Sally down there, by the way. There's not a small person. It's just a video monitor. Distance has become, I think, so please don't hear what I'm not saying, but it's become the thing that we all look at and we say, if it's within a 90-minute drive time, then that's where we want to be. A few years ago, that was a radius as an example, right? And we looked at a dot on a map and it was a circle of 90 miles, and this was everybody. When we started to become more mature at the association and we brought in data layers and we start to analyze drive time instead of circles, we found, so I don't know what the rest of the world is like, but in America, our interstate highways run up and down and north and south mostly, right? Except in Atlanta when it's like somebody just threw stuff on the ground. So what happens though is that now that 90-minute drive time becomes like a polygon. It's a diamond, right? Because it's following a major north-south artery and it's following a major east-west artery. So I would say this, let's call it the low-hanging fruit, to say, yes, if people are close to a clinic, it's easier to get to. That's the truth, obviously. That's a truth, not the truth. But if you picked up on it, 60% of people in the United States, only 60% of people in the United States who live within that standard of drive time actually still attend a clinic. And so we could, and again, please, I'm not. If you want to have a conversation about the overall impact and mission stuff, see Dr. Thacker. But we could get more people into multidisciplinary care by getting that number raised from 60% to 80%, because you saw the heat map. That's where people are, right? We could get more people into multidisciplinary care by figuring those things out and knowing what those levers are than we could by putting a new clinic within 90 miles an hour of something else. And that sounds terrible. Don't, please, please, please. I'm not saying that it's not important to cover those things, but the two solutions are different, right? Maybe it's, do we have a place that has accessible transport? Maybe we have a place where it's difficult for someone to find if they need overnight stay. Maybe there's a clinic, and I travel a lot with my boss. If you've seen her go around here, Tina, on a scooter. We were somewhere in DC, and we went 99% of the way we needed to go, and there wasn't a button to push for the door to be opened, and she couldn't reach it. Her chair just, we went to another place, there was a garbage can in a hotel in front of the buttons, and she couldn't reach it. So maybe that's what's keeping people out. Maybe we know that people in different ethnicities have different issues with finding care. Sometimes I spoke to at one of our roundtables to a doctor from Dr. Michelle LeBlanc. I think that was her last name. She works at an organization called CASA in DC, and they work a lot with immigrant families coming in from Latin American countries, so Spanish-speaking. She was talking about the COVID vaccine and that someone had Google translated the document, and instead of telling them to go and get their shot, was telling them they were going to get shot. We don't know what those things are, but the different barriers have different needs. So if there's a takeaway, it is easy to say yes. You know, the gold standard is 90 minutes. Maybe that's what it is. But find out what's keeping people from the places where they could get to as well. That is equally, if not more important, for volume. I'm sorry, that's a convoluted and long answer to a question that was asked to be really quick and easy.
Welcome to the field of ALS, where every time you answer a question, you get deeper into a Alice in Wonderland hole. Sally, did you have any comments?
Very, very similar picture, I suppose. We've definitely seen a pattern around ultimately issues that are about geographical variation and about what that might look like in terms of more rural areas and how far specialist centres are able to support people to travel to or reach out to areas that are a bit more difficult to travel to in terms of transport. But exactly as what Dean's just highlighted, what we've started to do is really think about it through the lens of health and social care inequalities and start to dig a little bit deeper, I suppose, beyond that initial geography point. And so we're going to be doing a piece of work actually in the next 12 months whereby we just want to understand that picture a little bit more. And so health and social care inequalities, as you would expect, is top of the priority for our health system colleagues across the UK at the moment, thinking about how we make healthcare fairer and more accessible to all. So actually there's a joined up kind of message, I suppose, about us going in and making sure we're thinking about that from people affected by MND's point of view and saying, okay, what do we understand about the local need here? How can we actually look at this in a more holistic way rather than just looking at geography as the absolute, making sure we actually understand all the different variables that might be at play that might be meaning that people don't actually access that clinic. Some of it might be preference, and I think there's a really important piece that we're trying to build into this piece of work, which is about how we personalise healthcare as well as make it more accessible and make sure that we to respond to people's needs and all of the opportunities around digital healthcare and virtual support that we know we've seen happen through COVID. So we're really we've started very much that kind of geographical feature has been part of the work we've been doing, but we're wanting to kind of get beneath the layers really now and understand that with our partners really about what that's looking like and what some of the other barriers might be.
Excellent, thank you. Well, it feels like this conversation could go on a lot longer, so Sally has given us her credentials so that we can contact her, and Dean's still in the room for a while longer, so please feel free to grab him. And hopefully today's conversation has helped you to think about ways that you might look to that data, look at how it can have an implication for multidisciplinary care, and that we've been able to learn something from our partners. So thank you.
You're welcome.